Hello, my name is Adlin Lawrence, and today I'll be sharing an intriguing and complex case involving a patient who was on chronic immunosuppression therapy and was found to have simultaneous infections with three distinct pathogens. It's a very rare and fascinating scenario, so let's dive right into the case. A 68-year-old male with history of end-stage renal disease requiring bilateral renal transplants who was on immunosuppression therapy for the past 15 years presented to the hospital with 5 days of diarrhea and right upper quadrant abdominal pain. Initial labs were significant for elevated liver enzymes, and his kidney function was stable around his baseline. Because the patient was on chronic immunosuppression, we decided to check his CMV viral load, which revealed significant CMV viremia with more than 2 million copies. Because of the ongoing diarrhea, a GI multiplex panel was also done, which revealed concurrent infection with enteropathogenic E. coli. For the same complaints, patient underwent a colonoscopy which revealed diffuse patchy erythema on visual inspection. Colon biopsies were taken which revealed the following. As you can see in figure 1, the green arrow is pointing to what are the CMV bodies on the immunohistochemical stain. Similar bodies are visible on figure 2 on the H&E stain of the colonic mucosa specimen, as highlighted by the green arrows. The patient subsequently developed bilateral CMV retinitis as well. In the midst of all this, the patient tested positive for Epstein-Barr virus with significant EBV viremia as well. This EBV viremia in the setting of prolonged immunosuppression raised concerns for post-transplant lymphoproliferative disorder, but no lesions could be identified. The patient was treated with IV ganciclovir and intravitreal ganciclovir, which were later transitioned to oral valganciclovir. His immunosuppression regimen was also modified in that his belatacept was changed to tacrolimus. The patient eventually recovered with multidisciplinary care, his symptoms resolved, his liver functions normalized, and he was discharged with infectious disease follow-up. So now that we've gone through the case, let's see a few points which make this case very unique and interesting. Firstly, as we all know, CMV infection is a very well-known complication in patients on immunosuppression therapy post-solid organ transplant. This case highlights the potential that CMV holds to turn into multi-organ involvement, as seen in this patient with pancolitis, retinitis, and CMV viremia. Given that the patient had three distinct pathogens, the question arises, what came first? Well, the conjecture is that given the high degree of CMV viremia and multi-organ involvement, CMV was likely the first infection in this patient, which paved the way for him to develop E. coli and EBV infection as well. The EBV viremia may represent a state of over-immunosuppression, which has been documented before. The decision to change belatacept to tacrolimus was a very pivotal adjustment to the patient's immunosuppression regimen because belatacept has been known to increase the risk of CMV in post-transplant patients. In conclusion, this case underscores the importance of maintaining a high degree of clinical suspicion for opportunistic infections in transplant patients. The three main keys for management of such complex scenarios is vigilant surveillance for opportunistic infections, multidisciplinary management, and nuanced adjustments to immunosuppressive therapy, which will lead to better outcomes in complex scenarios. Thank you.